She was selected by UPSC to be the principal of RAK College of Nursing and stayed on for 14 years in this profession. A warm word of welcome to Mrs. Vandana Bhattacharya, President of SOMI Delhi State Chapter and former INC President New Delhi. Ma'am, we are waiting with full of ambulance to listen to your...
To be giving some keen thinking about what I think. I'll tell you, when I have come and in this university for some time, what was very heartening when I reached yesterday very late, the people who came and welcomed me say, "Ma'am, how are you?" I said, "How do you know me?" He said, "You taught us midwifery nursing." I said, "That's good." And that felt so nice. And one university has given me a friend in Rivan, Philadelphia, USA. She's a midwife, I am a midwife, and our first meeting just come together. And I think of the Eternal University. Obstetrical nursing, new insight in research, diagnosis, and of the great progress that has been advanced and achieved in the specialty in recent years, the main area being the reduction of and perinatal mortality rate. This is mainly due to the development of science, development, innovation, and discovery of newer technology in diagnostic, latest techniques, recent midwifery care, and the application of midwifery model of care on maternal health. Obstetrical and gynecological nursing is a field where tradition meets innovation. As a nurse working in obstetric and gynae, we have a wide responsibility to take care of women from puberty to menopause, helping the woman during pregnancy, labor, childbirth, postnatal period, as well as women's health issues related to the reproductive system. The trends and development of research in the field of obstetric and gynec nursing has changed with more focus on evidence-based practice, which looks at research findings, quality improvement of data, other forms of evaluation data, and expert opinion to identify methods of improvement. The purpose of evidence-based practice is to assist in clinical decision making, and evidence-based practice shows how research can also play a role in forming clinical decision. Evidence-based practice is a philosophy and a process which is logical, sensible, and scientific. There are frameworks and processes that meet a need of certainty and structure. The advancement of professional nursing essentially requires integration of theory, practice, and research, and collaborative nursing research is a realistic mechanism to achieve this. Nurses are working on clinical research studies in many professions. Evidence-based nursing practice is a way of helping with everyday tricky decisions that can be quantified and justified. And the main aim is to achieve better and improved patient and client care. It is necessary that every practicing nurse, health practitioner should develop the skills associated with evidence-based practice and also try to adopt a personal evidence-based practice philosophy. Nursing Research Society of India was born in 1990 with a purpose to encourage nurses working in the field of nursing education, administration, practice, and other related health issues, and to undertake research studies to improve and provide better patient and client care with focus on clinical nursing practice. The Society also publishes the Journal of Nursing Research Society of India with a view to disseminate the research findings conducted by nurses in different clinical areas such as obstetric and gynecological nursing, pediatric, psychiatry, community health, etc. The Global Research Nurses Network UK was established in 2006 to work and collaborate with nurses across the globe. Its goal is to provide resources and support to nurses who are working in research, predominantly from low and middle income countries, to invite all nurses to join the network and have their role in research recognized. The Global Nursing Research Network offers online networking, holds regional events where research nurses from local area meet to share experiences and develop collaborative links. In India, during 2013, 14 workshops have been conducted in Trivandrum and New Delhi. Miss Athira Rani, a nurse from Kerala, was invited to attend the International Nursing Research Conference in Glasgow. In India, nursing research is becoming popular among nurses, but still we have a long way to go. There are many challenges and issues faced by the nurse researchers, but with determination, sincerity, and hard work, we will be able to overcome the hurdles. And I am sure the Almighty will always be blessing us in this endeavor that we do. Thank you very much for patient hearing.
Thank you. A person unconditionally, a character builder and heart healer, of creation, inspiration and love. She is the one who raised, nurtures and protects the children. She is the maker and keeper of wonderful memories, a person much loved and greatly admired. She is Mother. Now let's move towards the plenary session 1 on new insight into diagnosis and clinical care in gynecology and obstetrics. So before starting the plenary session first, I would like to inform the chairpersons and members of concurrent session 1 to move towards the auditorium. The chairpersons are Dr. Rajinder Mahal, Dr. Satwant Tej ma'am, Dr. Asuma Bibi and Dr. Jane Green, and the presenters and the participants are Miss Pallavi, Miss Lithia, Miss Navanpreet Kaur, Miss Amandeep Kaur, Miss Kamlesh, Miss Amrita Saini, Vinothi, Miss Mamta, Miss Rupinder Deol, Miss Anukiranjit, Miss Amandeep Kaur, and this session will be till 1:30. So I feel privileged to have distinguished chairpersons among us, as they all need no introduction, having spent valuable years in nursing. I may be permitted to give a brief introduction about their accomplishments, academic attainments in the chosen field. So I am going to mention the names of the chairpersons for plenary session 1. Dr. Hemchandra, medical graduate presently working as professor and medical superintendent of hospital administration at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India. He is the first professionally qualified hospital administrator, research teacher in UP and Uttarakhand, various national level committees, including Go India and member of State AIDS. So we request Dr. Bandana Bhattacharya ma'am and Professor Hemchandra to please come on the stage and take your seats as a chairperson.
So we'll start with our first session. For that, I would like to call Dr. Reena Bose, as you all are familiar with her. I request you, ma'am, to please come on the stage and give some information regarding perspectives of maternal and child health in rural India.
I'll just click it now. Shall I click it? Start it? Yeah. Yeah.
Have you made it in Word, ma'am?
Huh?
Word? We have this presentation.
Yeah, presentation, that one. Yeah. First, slides are there. Oh no, this is the slide I want. See, these are the slides. Prospect.
Ma'am, did you put it in PowerPoint?
Yeah, PowerPoint. It's in the
and gentlemen, both the chairpersons, welcome on behalf of the organizing committee and this society and the charitable trust at the Baru Sahib. And we are extremely thankful to the organizers and the especially to Madam Sujana, Professor Sujana Chakravarti, Professor Chauhan, Professor Madam Kaur, and other faculty of the and the staff of this college, Akal College of the Nursing, and really amazed and surprised to see this place. Like yesterday, Major General Kandal was telling that it was, I will complain to the God that he has not given us the way to come this far before this time. So really I am also thinking the same way. And really it is our good luck that we could have a good glimpse of Holy Babaji this morning also. Though we went at his place, ashram, yesterday also. But I am very grateful to all of you for having attended this place and also invited both of us to be a chairperson of this particular first technical session of this program. And I am heartily welcome to the delegates and the dignitaries and the invited guests from the abroad, from the US and other places. And very thankful to them that they has given the kind cooperation and the collaboration for the last 5 to 6 years for this conduction of this international program and the Akal College of Nursing. It's a plenary session. To begin with the session, I invite Dr. Reena Bose. Reena Bose, as you know, she has already given the keynote address before starting this program. Presently, she is the nursing advisor at the St. Florence College of the Nursing College, Calcutta. And Madam, warm welcome to you again to this floor, and hopefully that we all enjoy your experience with the exchange program, and after your good thoughts and the deliberation. And then I give this mic to my colleague, to Madam Chakravarti.
I think you can now start your presentation, and after the presentation we'll be able to do that.
You can say now.
I don't. Yeah, I'll do it. Thank you very much. My very dear nursing fraternity, I'm sorry for the delay. This always happens when you want everything in time. I'm thankful to the organization for giving me this opportunity to express a subject which is very dear to my heart. With a personal experience, I present this paper to you, and you can ask me any question, criticize whichever way you want, and I want you should do it. My topic is Perspective of Maternal Health in Rural India. Much has already been dealt with the topic in general by Ms. Vandana Bhattacharya. However, my objective is to deal with that topic particularly applicable in rural India. Also, I especially want to focus on the role of nurses and mortality in the country. The maternal mortality rate in India at present is 301 per 100,000 live birth estimated in 2009. In Himachal Pradesh, as I got it from the internet, is 456. You see, it is very, very high in hill areas, that is in Himachal Pradesh. And see, in India as a whole is 301, so it is in Himachal 456. So I think Akal College of Nursing should play a special role in bringing down the maternal mortality of the Himachal Pradesh. And I think I have faith that they will be able to do it. I'm dealing exclusively with maternal health as I had some experience of difficult labor and I know the agony and suffering of a young mother undergoes. The main problem with health in rural India is the high rate of mortality. Maternal mortality rate in India is 300,000. I have already 100,000 live birth as estimated in 2009. Most of these preventable with proper care. That is the sarcasm. Maternal deaths usually occur around labor, delivery and immediate postnatal period, and nurses and nurse auxiliary have a special role in bringing down the maternal mortality in the country. Debilitating disabilities. I am stressing on nurses' role as most of the deliveries are conducted in the villages either by the nurses or auxiliaries or DICE. So I think they should take up the major share of responsibility of bringing down the mortality rate. In 1880, British government started DIE training at Amritsar in Punjab in order to bring down the maternal deaths. Maternal death was so high that coming to know about it, Queen Victoria ordered action to be taken immediately. So 2 Lady Dufferin hospitals were set up in India at Amritsar and at Calcutta for exclusive care of the mother and child. Focus on safe motherhood was not so much emphasized when in 1946, according to the Bhor Committee report, new model of healthcare system emerged out in free India. However, with progress of healthcare in general, sub-centers were set up to provide maternity care at village level by the ANMs, that is auxiliary nurse midwives, who were supposed to work under supervision of the nurses. However, their supervision was not enough and maternal care deteriorated as job responsibilities of the auxiliary nurse midwife expanded under the multipurpose health workers scheme. Maternal care further deteriorated as auxiliary training was cut down to 18 months duration from 2 years period. Perception of care for the ANM was changed from maternal care in family welfare to family welfare and also importance of a role in immunization as an immunization worker was much emphasized. As a result, maternal care could not improve to bring down the maternal mortality rate. In 1992, second ANM was introduced at selected primary health centers to provide 24 hours service for delivering the mothers. Janani Suraksha Yojana was also introduced with cash incentives to motivate mothers who are below poverty line for institutional delivery. But still yet, only 40% deliveries are conducted at health facilities, and most of it is in the private sector, not in the government. To improve MMR, subsequently ANMs were allowed. Administration of antibiotics, at present they are allowed. They are allowed to give IV fluids and oxytocin drugs. ASHA project was introduced to motivate mothers for institutional deliveries. However, there is not sufficient improvement in bringing down the maternal mortality rate. Millennium Development Goal by 189 countries in 2000 has goal of promoting development, eradication of poverty, improving maternal health by reducing maternal mortality rate. Thus, it aims at reducing MMR by 75% by 2015. For India, aim is to bring MMR down to 108 by 2015. Safe delivery in India is at present 76 per 100 live births, which has to be increased from 76 to 95 per 100 live births to 2020. It has been said that preventable MMR, it has been said that preventable maternal mortality rate indicate violation of basic human right and also gross failure of available health care services. I feel nurses do share an important role in this failure. Maternal death occurs around labor, delivery, and immediate postnatal period, PPH being the main cause. Unsafe abortion is also causing maternal death. Half the maternal death occurs during postnatal period. Also, it is a fact that maternal deaths are concentrated in poor, disadvantaged women. Also, it is higher in low caste and scheduled caste as well as among the tribals. Unsafe abortion mostly occur due to one main cause is unmet family planning need. Medical Termination of Pregnancy Act has already passed many years back, but it could not be applied as desired due to two factors. Lack of trained medicos, doctors are allowed, they are not trained enough number. And secondly, the infrastructure for doing the operation is not there. In India, Kerala and Tamil Nadu, these are the two states who have made progress in reducing maternal death. Both the states have achieved it through compulsory institutional deliveries. Maternal mortality rate in Kerala is 95 by 100,000 live birth. Also, it has achieved 100% institutional deliveries. Tamil Nadu has maternal mortality rate of 111. Tamil Nadu has introduced a special scheme for the below poverty level mothers by giving them 60,000 rupees to any pregnant mother irrespective of the parity and the other help. They give this money particularly for mothers' nutrition and transport facility during delivery. There are many aspects to MMR. aspects of 2 MMR and safe delivery, which has to be shared by different health workers at different level. However, who plays the major role? It is no doubt that the nurses and the auxiliary workers who are trained for the job and who are present in the rural area in majority, they share the main responsibility. You can say what a nurse can do if there is no facility as transport, cesarean section, intravenous infusion or blood transfusion facilities. Yes, I do agree. But what are we doing our best in the existing situation? Are we reaching all the mothers of my area and giving them sufficient information and education in time to avoid the emergencies related to childbirth? Are we doing it with our conscience? With some experience in community health field, I had a feeling that nurses, including auxiliaries, are not always very confident of the information they need to give to the mothers or teach the elders of the family. In spite of government's effort, they are not always up to date in their knowledge and practice. Nurses' most important role is educating the client and her family after being confident of the knowledge and responsibility they bear. Studies by UNICEF and other agencies have found out that in rural areas, mothers die namely because of 3 reasons. Firstly, late decision to go for interventions when complications arise in delivery. They cannot decide whether they will go out of their house to somewhere else. Secondly, difficulties in arranging for a transport to take the mother for help when the complication arises. And thirdly, insufficient arrangement for intervention of labor at the center itself if at all mother decide manage transport and reach there. All 3 are preventable, no doubt, and the persons present are usually the DAI or ANM or the supervisor or maybe the ASHA workers. So it is expected that all of them ensure that this situation does not arise. In all the antenatal checkup, teach mother again and again the following informations. First, complications of labor can occur at any time during delivery. You have to teach the mother from the very beginning. Secondly, early signs of these complications. What are the early signs? Mother and all other family members must know. Thirdly, sources from where family can get the transport. They don't know, they're ignorant, they're very poor. They somehow manage their food only. They don't know where to go for the transport. Involve ASHA workers. Government has spent a lot of money. Involve them, make them responsible to help them to arrange transport. Be sure where you will refer to instruct them to take the mother. You just don't say go to this PHC, that PHC, or this place or that place, this first referral place or not. Be center, because where do you recommend, it must have be well equipped for interventions of labor, and also make sure a doctor who can perform CS. I have known cases been referred to a PHC where there is no doctor to do the cesarean section. So make sure it's your responsibility that you know a center where doctor is there to do the intervention properly. Since on principle, institutional deliveries are desirable, this has been universally accepted, and almost made mandatory. So teach the mother from the very beginning, prepare her attitude to plan for institutional delivery. All these teachings have to be given not only to the mother, because mother has no voice in her delivery. But she has no opinion, no voice. But to the head of the family, who may be the mother-in-law, maybe husband, or any other person of the family. Remember, 20% deliveries missed at the institution because of their proximity. Most of the placements are so far away that 20% deliveries cannot go to institution. Therefore, arrangement has to be ensured much earlier. Enforce again and again advantages of institutional deliveries. Panchayats are there in the villages. They help to provide transport. There are nowadays many non-government organizations are coming up for providing help for transport at the village level. In Tamil Nadu, government has circulated a unique device, that is a district level telephone number. You just dial that number from any village and you will get a response and arrangement of the transport will be made. These are the things which has helped Tamil Nadu and Kerala to achieve. In conclusion, I would like to point out that there was once an effort made by the government to train graduate nurses in advanced midwifery practices and care to bring down maternal mortality rate, except cesarean section. In my state, that is in West Bengal, there were few graduates, about I understand 10 to 12 of them, who were trained specially and posted at PHCs, but I think the special post had its natural death. The project might not have been continued due to lack of sufficient support. Here I would say we cannot blame the government alone. We nurses never showed enough enthusiasm, enough able to take the responsibility of delivering the mothers at the complicated labors, conducting them, helping them at the village level. So I think this was a unique project, but it has not taken up in any other country, and I think Miss Bandana Das, who was fully involved, she was in charge of it, and you may ask question to her, she will be able to tell better than me about this project. Lastly, I would say, let the nurses of India take the initiative to help bring down maternal mortality of India to 108 per 100,000 life path and achieve the Millennium Development Goal 5 targeted by 2015. I hope I'm clear what I wanted to express, my feeling. Lastly, is there 2 minutes more time I can take? Can I take? Or it's over?
First speaker, you have that privilege.
2 minutes. Huh? Yeah. You see, I'm tempted to tell a personal story. I would have added one more maternal mortality to India the year I had my first delivery. I broke my water bag 12 noon and I was admitted to the very Lady Dufferin Hospital for my first delivery by a Jewish doctor specialized in maternity. Anyway, after I was in the labor room, and when I was admitted I was all right. By evening I had my labor pains, and whole night I had severe labor pain. Towards the morning, I said I cannot bear any more. I was praying to God that I have no other wish but to die. But by 8 o'clock, the residential medical officer came in and I told her, I don't want to live anymore. Please let me die. I don't want to have any baby, nothing. She said, no, 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 don't worry. I will do something. And I was almost fainting, and I could hear she ordered, Martha, the nurse in charge of the labor room, come and give fundal pressure. I thought, well, the fundal pressure will help me to die earlier. So I was rather happy. I thought, Martha looked at me, said, Madam, don't worry, I will do my job very well. I said, good. Then, I don't know, after that I don't remember anything. But I could hear the RMO is telling to another sister in charge, give me the high forceps. I'm going to deliver her with the high forceps. I said, good, I will go to heaven very soon. Anyway, after that, I don't know anything. By evening, when I was awake, I was shown, Sister Martha came and said, Madam, you have a son. I said, I'm alive. Am I alive? She said, yes, you're alive. I thought, I'm gone. But then she showed me my son with a big mark on the face of the big blade with the high forceps. So that was my experience, and with that feeling, I'm presenting this paper to you. Thank you all for patient here.
Thank you for presenting so well the topic, and I think you have given the picture very well of it, and we have a long way to go. It is good that Kerala and Tamil Nadu has achieved. There is no reason why should other states not achieve. And I had last comment that the nurses of India should take a pledge to see we bring down the maternal mortality rate. If not but 2015, because I am working in midwifery, so I know we may not be able to reach the goal, but we should think that we must bring, if not 2015, maybe 2020. Thank you, Reenat.
I will just add up one, madam, even this 108 Thank you so much, ma'am.
Let one announcement. Ladies and gentlemen, due to the shortage of the time, we will have a discussion at the end of the session. And secondly, I will request to successive presenters to be limited with 10 to 15 minutes. That's fine, so that we can have the early lunch without going cold. Thank you very much for that.
Thank you so much. Next, I would like to call Mrs. Prasanna J, HOD, OBG and Assistant Professor in College of Nursing at AIMS in Rishikesh. She has around 10 years of experience in this field, and she has also organized and conducted various conferences. Ma'am, please come on the stage and share your ideas regarding new techniques in maternal and obstetrical nursing.
So I just want to do the humble request to two participants, Ms. Anukiranjeet Kaur and Ms. Amandeep Kaur. They have not reached auditorium yet, so they are requested to move to auditorium for their presentations, please. Ma'am, you can go. Yeah.
Good morning, everyone. Dignitaries on the dais and off the dais, and dear delegates. I thank the organizers for giving me such a wonderful opportunity to present a paper in front of you. So I'd like to start the topic. So today I'm going to speak in front of you regarding new technologies in clinical obstetrical nursing, especially regarding management of shoulder dystocia, open fetal surgeries, and vaginal birth after cesarean section. So when you talk about shoulder dystocia, all obstetricians or maybe the midwives or the nurses who work in labor rooms, they may think that whatever the situation it is, we should make it best by facilitating the mother or by minimizing the complications to the mother and fetus. Shoulder dystocia is very like devastating situation in the labor room, you can say, and many deliveries which occur with shoulder dystocia, they end up in some other type of complications either to the mother or maybe to the fetus. And the incidence, if you consider, it is almost 0.2 to 2%. It is lesser than that, of course. And the main goal we have to keep in mind while managing the shoulder dystocia, it should be like the maximum minimizing of complications to mother as well as fetus. And the shoulder dystocia refers to the failure of shoulder to have its own rotation or spontaneous rotation during the vaginal delivery, or the obstruction of the anterior shoulder under the symphysis pubis. The main pathological aspect of shoulder dystocia, it is the anterior shoulder may got stuck under the symphysis pubis, or it may be because of the increased bisacromian diameter of the shoulders, the diameter between the two shoulders, or it may be because of mismatching between the fetal size and the pelvic size of the mother, and maybe it is because of positional variations during vaginal birth, and because of that the uterine contractions may be continuous and spontaneous. The force is coming from the top and the fetus is having difficulty to expel. So that time there is a chance where the major damage which occurs to the brachial nerves. The shoulder dystocia may be mainly two types. It may be unilateral or may be bilateral. So in unilateral shoulder dystocia, usually it happens the anterior shoulder alone gets stuck under symphysis pubis. When in case of bilateral shoulder dystocia, both the shoulders, anterior as well as posterior shoulders, get stuck under symphysis pubis as well as in the like posterior shoulder. Usually it should come into the hollow of the sacrum, but in case of bilateral shoulder dystocia, it may stuck in above the hollow of the sacrum. The considerable risk factors or the causes may be related to antepartum or may be intrapartum. Antepartum factors like maternal obesity, especially in case of diabetes mellitus, or maybe because of post-pregnancies or excessive weight gain of the mother during pregnancy. So these all causes may lead for the macrosomia of the fetus. Intrapartum factors, prolonged second stage of labor, or like a very rapid induction of the labor by administering oxytocins, or maybe forceful or rash application of mid-forceps or maybe vacuum extractions. In other way, if you are considering the risk factors related to maternal and fetal factors, maybe it is because of mismatch between the fetus and pelvis, what we call it as CPD, cephalopelvic disproportion, or maybe the gestational diabetes, all these things, and these are all leads to fetal macrosomia. And also in male fetus, usually the incidence of shoulder dystocia, it is more. In this picture you can observe the relation between weight gain of fetus during pregnancy and the incidence of shoulder dystocia. So usually the shoulder dystocia, it is more in case of the fetal weight is more, especially which falls under 90th percentile, the incidence is more. How should we diagnose the shoulder dystocia? So usually we may be expecting spontaneous delivery of the fetus during normal vaginal delivery. After head, once it is out, we'll try to pull out the baby without any thinking. So thinking that baby will spontaneously deliver. but everybody should be alert at the time whether baby is spontaneously delivering or we are forcefully removing it from the uterus. So there 1 second of time you have to take to decide whether everything is all right or no. So here you may be suspect that there is a presence of shoulder dystocia, whether there is a resistance of delivering or resistance in internal rotation of the shoulders. At the same time, the fetal face become plethoric, puffy and reddish, or swelling will occur on the face, and maybe you can define like turtleneck sign, like when turtle gets some obstruction, how the head it takes inside. So in the same way, sorry, I think the animation problem. So how the turtle takes his head inside, the same way the fetal head also goes back towards the maternal pelvis. So that is one of the important sign we have to observe for. So our consideration is today regarding the management of shoulder dystocia. Commonly, once you identify the mother with or baby with shoulder dystocia, will have to be calm for a second. Think what you have to do. Don't be panic, and at the same time try to have quick actions. So here the common mnemonic we follow to manage shoulder dystocia, it is helper. It refers for H, call for help, evaluate for episiotomy, leg hyperflexion, otherwise known as Microbert's manual, suprapubic pressure, enter into the internal rotations, remove the posterior arm, roll over the mother on all four positions. So we'll have a quick discussion of all these methods. So already because of shortage of time, it has been instructed like try to be quicker and shorter. So we'll have a quick discussion. So first measure you have to take it here, it is gentle pressure. So maybe simultaneously when you are waiting for help from other members, just once you can try for gentle pressure, like holding the neck firmly with both the hands, try to have downward and outward, simultaneously upward movements, so that there is a chance for slipping of anterior shoulder from the symphysis pubis and spontaneous delivery of the baby. At the same time, remember that excessive application of force may damage the brachial plexus, and at the same time the rotation should not be more than 45 degrees. In helper, H, like you have to immediately call for help. Maybe you should need adequate people like nursing personnel, obstetrician, pediatrician, anesthesia, and other members for any other type of help. So immediately you should have that, and at the same time whatever the hospital policy protocol is there, we can follow that. Then E, evaluate for episiotomy. So don't think that giving abundant or adequate episiotomy may relieve the shoulder dystocia, not at all. Maybe it may create greater room for or greater space in the pelvis, but at the same time don't consider after giving so much episiotomy baby will deliver, because this is a bony obstruction. The shoulder is obstructed under the symphysis pubis. Second one, then leg hyperflexion. So this is the initial step we take. Ask the mother or you help the mother to hyperflex the thighs while knees are flexed. So that what it does, you actually in Mick-Roberts manual, when you are hyperflexing the thigh and towards the shoulders on the mother's abdomen, the symphysis pubis rotates anteriorly and superiorly, so that there is a chance for escape of obstructed shoulder of the fetus towards down, and also it facilitates the escape of posterior shoulder, so that baby can be delivered with the oblique rotation. Next, if McRoberts maneuver gets failed, then you have to step to the next method, that is application of suprapubic pressure. So in this, along with the hyperflexion of the thighs of the mother, slightly give the suprapubic pressure with our dominant hand. So there you have to be very careful. Try to find out the obstructed shoulder of the fetus. On that only we have to give. So when you give the suprapubic pressure of the anterior shoulder, so slightly it may go down and try to have spontaneous rotation into the oblique diameter of the pelvis. If that McRoberts maneuver and also suprapubic pressure if gets failed, then you have to think about other rotations which we do internally. Internal rotations we have to go for. Here internal rotations also we have to always keep in a mind, like rotation is regarding shoulders, not the head, external head. Never rotate the head, otherwise there is a chance for twisting of neck that may create asphyxia of the fetus. So always remember, internal rotation is regarding rotation of the shoulders. So in first rotation about internal, it is Rubin's maneuver. So here during the vaginal examination we have to push down both the fetal shoulders towards the fetus chest, so that when both the shoulders of the fetus got pushed together towards the chest, the diameter, bisacromian diameter may decrease, so it may escape from the pelvis. The other method, it is Wood's corkscrew maneuver. So in this, complete rotation of the shoulders from the anterior to posterior. Then next one, other method you may try for removal of the posterior arm first, then removing the anterior shoulder. Finally, the other method you can ask the mother to roll over on the all fours position, like in the legs and knees position. So in that there is a chance for slipping of baby simultaneously. So after this, after trying all these methods, if the still baby is in, then the final steps which we use is Junilis maneuver, that is cephalic replacement. So this is also one method, like baby's shoulders are rotated obliquely and push the baby inside the uterus, then send the mother for emergency cesarean section. The other method which we use in case of abnormal or anatomical defects, or if the baby is dead, symphysiotomy, that is opening of symphysis pubis, but it is very dangerous and very rarely it is followed. Then final step, clidotomy. This is also one method where internal clavicular fracture it is used. So if the internal fracture if you do, this is easily healable after delivery of the baby, but practically I think nobody is there to do this. So some of the maternal and fetal complications are there that we are not dealing. So the next topic we are going to just mention about it is open fetal surgeries. So open fetal surgeries is not the new topic. From 1965 there are trial of fetal surgeries, and the first time open fetal heart surgeries has been done by Dr. Mitchell. He is the father of fetal surgeries. So here the fetal surgeries are nothing but manipulating the fetus intrauterine period to facilitate the fetal life for better development. So maybe these fetal surgeries they may do for anatomical correction of any types of defects, or maybe twin to twin transmission syndromes, or maybe trap, or it may be done for the anomalies of placenta and membrane. And a few contraindications are there. There may be any types of chromosomal defects or any other severe anatomical problems of the baby which cannot be rectified. In those conditions, these are restricted. There may be few advantages, like during intrauterine period, if you do any type of operations, they are healed very easily and also very soon, because the maternal blood circulation and oxygen supply is very well utilized by the fetus. And the types of surgeries are maybe open fetal surgeries. open fetal surgeries or fit endo, fix and exit. Ma'am, is it for half an hour or? Okay. Sir, I know because topics are three, I made it very short. So I'm so sorry. Okay. So the main types are open fetal surgeries, fit endo, fix and exit. So very brief discussion about all these types. Open fetal surgeries, they do by opening of the abdomen like LSCS only. The mother is given under general anesthesia. Whatever the identified problem it is there, they correct intrauterine by opening the abdomen and they again replace the fetus. Main examples are like lobectomy in case of congenital cystic abnormalities, resection of sacrococcygeal teratomas, repair of some types of meningomyelocele and other types of surgeries. The other type is fit endo. It is fetal endoscopic surgeries or minimally altered fetal surgeries. So here with the help of fetoscope, they'll try to manipulate something whenever there is minute defects of the intrauterine life. They used to repair it. In that, especially like TTT, which is very common, twin to twin transmission syndrome, they try to coagulate the vessels. And in case of TRAP, that is twin reverse arterial perfusion, they do cord ligation. So especially related to the placental problems, this surgery is done. Next, fix, that is fetal image guided surgery. So in this, with the help of both fetoscope as well as ultrasound, so they'll try to visualize the intrauterine environment of the fetus as well as placenta, and minute corrections are done, especially like chorionic villi sampling, amniocentesis, cordocentesis, fetal skull skin biopsies. The last one, it is exit procedure. Ex utero intrapartum treatments, otherwise called as operation on placental support. So because usually these operations are done at the time of delivery when the pregnancy is completed. If any problems need to be corrected before delivery of the fetus, they do by opening the abdomen, and the blood supply will be continuing through the cord and placenta from the mother, and usually respiratory problems are corrected later when the fetus condition got stabilized. Then they'll try to cut the cord and deliver the baby. So some examples like tracheostomy in case of congenital high airway obstruction syndrome, resection in any type of cervical neck masses, and any congenital abnormalities in respiratory conditions. And as usual, like pre-operative evaluation, it is very important to counseling the family members, and also it is one of the challenging aspect for the nurses to make them understand and make them accept what is the importance of fetal surgeries and how they are important. Otherwise, what are all the adverse reactions that has to be explained, thorough assessment of the fetus and mother, and other important aspects related to operations. Then other challenging aspects, ethical dilemmas like who will allow, especially mothers of Indians, or who allows the fetus to alter during intrauterine life. So that is very God has given this, we don't want to alter any situation intrauterine. So that is the response usually we get from mothers. And maternal risks are there, fetal risks are there, and also during anesthesia, mother also have the effect as well as fetus also has it. Then after the procedure, it is important to give tocolytics to prevent the preterm labor. So that is very important. At the same time, maternal monitoring as well as fetal monitoring for the general well-being as well as to find out any complications. So this is very important. Then there are important point regarding fetal surgeries. It is about future possibilities. So few researches are going on regarding the stem cell replacement during any congenital sickle cell anomalies, and also in case of tocolytics use in better way, as well as improved techniques for the fetoscopic visualization of the fetus. The final topic, one more I wanted to stress on it, it is like vaginal birth after cesarean section. Maybe everybody would have experienced, like now it is from the vaginal delivery, it is trial of labor after cesarean. So there is no compulsion that mother has to undergo vaginal delivery. It is important to try, at least have a trial labor, whether it is possible or no. But many people, maybe from the mother's side force it is, we don't want to take any risk, or maybe obstetrician risk it is, like why to take risk, simple words but making the mothers to undergo major operations. So, once cesarean, always cesarean. This was the slogan. Usually it started in the years of 1916. After that, the rates of cesarean section increased in between 1980s and 1988. Later on, especially like American College of Gynecologists, they have encouraged for trial of labor. So thereafter, the initiative has spread around the world. So, in between 1997 and 96, the vaginal births after cesarean delivery, it was higher. Thereafter, the rates started falling down. But now, the total cesarean section rates are very high. So, trial of labor, it is nothing but planned attempt to have vaginal delivery after cesarean section. Once the mother has undergone cesarean section, next time consecutive pregnancies, they have to try for normal deliveries. If there is non-recurring cause, like maybe because of any fetal complications, if they would have done first time cesarean, later second time they can go for trial of labor. How to select the case? So here the few criteria are there. In that first one, one or maximum two previous lower term cesarean sections, and there should be normal presentation and maternal condition as well as fetal condition should be normal. If any abnormalities are there, they are contraindicated. They should not go for any trial of normal labor. And there are few benefits, especially maternal mortality rate it is will reduce if you go for trial of labor after cesarean section. And at the same time they should face some types of complications, maybe more rates of emergency cesarean sections are more. And at the same time there are success rates of trial of labor after cesarean section are more, almost 91%. Whoever tried for normal deliveries after cesarean section, the success rates are very high. So it is important to have initiation for every nurse or midwife to encourage and have guidance for the mothers to have. So protocol I am not discussing here because of shortage of time. Almost it is like normal delivery only. Only important thing here it is selecting the case for normal delivery. Who is eligible, who is not eligible for trial of labor after cesarean section. And final one focusing point I would like to say, recommendations for midwives. What is the important role of midwives in having trial of labor or vaginal birth after delivery? So that is a very thinkable question. Is midwifery is alive in India today? I am not going to give the answer here, just I am leaving it for the open audience. I think everybody is able to think and have answer. So, and moreover time is very short, so I would like to stop here.
Thank you, Prasanna. And I think it has added to a lot of knowledge, at least regarding fetal surgery and VAC. My experience in shoulder dystocia as a tutor in the labor room managing, I only can remember giving shoulder pressure, trying to rotate the shoulder and give a very long episiotomy. Luckily, the baby was safe, the mother delivered. But I saw that sign which you were saying, puffiness of the face and all.
Total neck sign.
Total necessary. And that time, the year I am discussing, 1962. So that time these macrobirths and all these techniques were common, neither did it come to practice. Now they mean this, and that as only 2%, and the diagnosis has to be very, it's very difficult to diagnose because you have to really have techniques, your experience to see that the baby is taking time and that there is a time delay in shoulder delivery. Thank you very much, Ms. Prasanna.
Thank you, ma'am. And before I could come down from the dais, I would like to thank Dr. Suresh K. Sharma. He is Professor and Principal, College of Nursing, AIMS, Rishikesh. So, for encouraging me to have part in this conference.
We beg excuse for having interrupted you many times on the way, though
So
however
sorry.
you have taken your full time.
Yeah, sir, I have prepared for half an hour.
No problem,
And
no problem. Sorry, but you should learn how to squeeze out. Sometime it happens, sometime it happens, sometime.
Thank you, ma'am. That was really knowledgeable for all of us. May I now request Dr. Amneek Kaur, Senior Consultant Gynaecology and Infertility Specialist, SGSS Super Speciality Hospital, Sohana. She did her senior residency from Government Medical College, PGIMAR, Chandigarh. Ma'am, please come and speak on new techniques in clinical care and adolescent gynecology.
Everybody, I'll be and make up for the last time. Topic for today is techniques in clinical care in adolescent gynecology, highlighting on PCOD, that is polycystic ovarian syndrome, menstrual irregularities in adolescents, the human papilloma vaccine, the sanitary napkins, the silent killer. So how do we define adolescence? It is described as the teenage years between 13 and 19, and it is a transitional stage from childhood to adulthood. It is associated with a lot of physical and emotional changes in the and needs due to various changes going on in the female body. Now, the field of gynecology, which is dealing with the problems of adolescent girls, is known as adolescent gynecology. The common problems, these can often be stressful because of academic, sexual, cosmetic expectations and from the teenage girls, and the peer pressures which are increasing day by day. Most of such problems are minor and at times just require counseling. What are the common problems adolescents are facing these days? Most likely menstrual complaints, leukorrhea, malignancy, fear of malignancy, genital warts, pelvic inflammatory disease, teenage pregnancy, sexually transmitted diseases, and lastly, the sexual assault. Coming on to the polycystic ovarian disease, it is most common endocrine abnormality in childbearing age group. Prevalence being 18 to 20% and is ever increasing day by day. Major features include menstrual dysfunction, anovulation, and signs of hyperandrogenism, which I'll be discussing. Now, most likely, like a teenage girl will walk into the OPD, obese, saying that मेरी menses कम आ रहे हैं या आ ही नहीं रहे, 3 to 4 months हो गए हैं. She'll have a lot of acne on the face and increased facial hair growth. That is a typical clinical feature of a PCOD patient. So the signs are infrequent menstrual cycle, no menstrual cycle, or abnormal uterine bleeding. Infertility, androgen excess, which manifests as increased hair growth, acne, oily skin, dandruff, baldness, and thinning of hair. Weight gain, darkened skin around the neck, armpits, inner thigh, vulva, and breasts. The pathophysiology is in the pituitary gland, which leads to increased LH secretion. Excess of androgens are secreted, that is the male hormones, testosterone, androstenedione, which leads to anovulation. The diagnosis is based basically on the clinical. We can come to know about the diagnosis on the clinical, that is the physical examination. Biochemical tests, that is the hormonal levels, and the ultrasound pictures support the diagnosis. The tests, there are a wide range of tests, but mainly we do total and free testosterone levels, free androgen levels, and the FSH and LH levels. Ultrasound obviously is a must. Now, Society of Obstetricians and Gynecologists of Canada, that is SGOC, recommends presence of at least 2 of the following 3 criteria. That is the oligo or anovulation, clinical or biochemical evidence of hyperandrogenism, which we've already discussed, and polycystic ovaries on ultrasound, which is diagnosed by more than 12 small antral follicles in an ovary and increased tomal density. Now, what is the treatment of the so-called polycystic ovarian disease? The basic treatment is lifestyle modification. That is the first and the only line of treatment, which consists of diet, that is low carbohydrate diet, fiber-rich diet, weight loss, exercise, and the stress management. Pharmacotherapy is reserved for the so-called metabolic derangements, such as anovulation, hirsutism, and the menstrual irregularities which occur. First line in regularizing the menses is the OCPs, that is the oral contraceptive pills. These days we have very low oral contraceptive pills for the teenage girls. Others are anti-androgens, that is spironolactone, that is to manage the facial hair and the acne. Hypoglycemic agents such as metformin and insulin, which are for the insulin-resistant cases. SERMs, that is clomiphene, is for oligo or anovulation patients in infertility. And we have topical hair removal agents such as afluoxetine and topical anti-acne agents for managing the facial hair and the acne. There are some other serious issues related to PCOD, that is the screening for diabetes by the age of 30 years in all patients with PCOD, including obese and non-obese women, should be done. RCOG recommends that at least a withdrawal bleeding of with progesterones, minimum every 3 to 4 months, should occur in a patient with PCOD who is not having menses. Now, nursing care. In nursing care, we should have to address the emotional stress caused by this disease. Information related to long-term risk of the disease. There are like long-term complications of the disease like diabetes, cardiovascular diseases, hypertension, hypercholesterolemia, and endometrial carcinoma have to be addressed. Healthy diet, exercise are the main lines of treatment. They have to be stressed. There's other causes of menstrual irregularities occurring in adolescents. Endocrine causes such as Cushing's, thyroid, premature ovarian failure have to be ruled out. Ovarian adrenal tumors also lead to menstrual irregularities, but the most important these days are stress-related hypothalamic dysfunction, medications, excessive exercise, and eating disorders. Anorexia, that is eating too less, or bulimia, too much. The next topic is puberty menorrhagia. Now, how do we define as menorrhagia? It is defined as excessive bleeding occurring between menarche, that is the time when you start your menses, and 19 years. In 80%, it is caused by anovulatory cycles. That is because of the immaturity of the hypothalamo-pituitary axis. It has to be individualized. Every case has to be individualized. And nowadays, since the increasing risk of the sexual assault and everything, we have to exclude pregnancy. Timely hospitalization, a thorough history, physical examination, and baseline workup are necessary in all cases. Reassurance, counseling of adolescent girls about the reproductive physiology, the changes they are going through, the regular follow-up, a balanced diet, and a long-term iron therapy go a long way. Now, there are some differentials, like why we have this puberty menorrhagia, that is excessive bleeding. Immaturity of the hypothalamo-pituitary axis being the major cause in 80% of the cases. Coagulation disorders, that is ITP, idiopathic thrombocytopenic purpura and von Willebrand's disease. Pregnancy complications, pregnancy always has to be excluded. Then the local genital tract infections, vaginitis, cervicitis, endometritis, and nowadays even drugs or hormones, they have to be all excluded before making the diagnosis. The immaturity of the hypothalamo-pituitary axis is a major cause. The goals of management, it depends upon how serious the bleeding is and ruling out all the anatomical and the pathological causes. What are the expectations and need of the girl? That is the need of birth control, contraception is there or not. Education, prospective charting of menstruation if mild, no anemia, only reassurance will suffice. And prevention of recurrence. Majority of the adolescents with abnormal uterine bleeding will spontaneously convert to normal menstrual cycle within 1 to 2 years. Education and support for adolescent and her family are very important because sustained heavy bleeding is very confusing and a frightening event. Now, factors determining the treatment option are age, parity, the need for contraception, and availability of the treatment options. The management depends thorough clinical and menstrual history. Sexual history is very important these days. General and local examination and assessment of severity depends upon the hemoglobin. HB more than 10 is mild, 8 to 10 is moderate, 5 to 8 is moderate to severe, and less than 5 is very severe. If the girl has mild puberty menorrhagia, reassurance, maintenance of menstrual calendar, pictorial bleeding assessment charts are there, assessment of menstrual blood loss has to be done, iron and vitamin supplementation are enough, and a periodic reevaluation has to be done. In moderate puberty menorrhagia, we have drugs like tranexamic acid, ethamsilate, or if not controlled by these, we can put the patient on hormonal support, that is norethistron acetate, which is a progesterone, or low dose OCPs. In severe cases, it may require admission, blood transfusion, thyroid disorders and blood trichuriasis has to be ruled out. Now this will be managed by high dose progesterones and other drugs like OCPs, tranexamic acid, mefenamic acid, and GnRH analogs like leuprolide, vasopressin. If not controlled, DNC has to be done even as a last resort, even in unmarried patients. The next topic is human papilloma virus. Highly prevalent in sexually active adolescents, highly prevalent. Causes warts and cancers, specifically the cervical cancer. Cervical cancer is the second most common cancer in women. Many strains cause cervical cancer, but the most common are 16 and 18. Now the scenario in India, more than 200 women in India die every day of cervical cancer. 8 women die every hour. That is, every 7 minutes a woman dies of cervical cancer in India. That much is the disease burden. Sir Herold Hassan is the one who discovered that HPV is the necessary key or link between cervical cancer and the cervical cancer, and he won the Nobel Prize for the same. Ian Fraser, an Australian scientist, converted this extraordinary discovery into the utilizable invention. He produced the HPV vaccine. Now, what does HPV cause? It causes more than cervical cancer. Cervical cancer association is almost 100%, but it is also the cause of vulvar cancer, vaginal cancer, anal cancer, head and neck cancers, and genital warts. And in males, it may cause penile cancer. Now, what is the natural history of HPV vaccine? HPV vaccine is acquired through sexual transmission. It invades the cells, persists as low-grade precancers. In 90%, it recovers, that is HPV clearance is there. In 10%, persistent infection may occur, which may lead to high-grade cancers, and finally cervical cancer. How does vaccination help? The vaccination induces higher antibodies in the blood and the site of infection. These antibodies, they neutralize the virus and they prevent the entry into the cells. What are the options available in India for HPV vaccination? There are 2 types of vaccines, Cervarix and Gardasil. The Cervarix vaccine, it has 2 HPV strains, that is 16 and 18, which are the major oncogenic types. And Gardasil is protective against 4 of them, 6, 11, 16 and 18. 16 and 18 being oncogenic and 6 and 11 cause genital warts. The regimen for the same is Cervarix has to be given at 0, 1 and 6 months, and Gardasil is 0, 2 and 6 months. Now what are the FOXY recommendations for HPV vaccination? Cervical cancer causes significant morbidity and mortality. HPV vaccine has to be offered to all appropriate females who can afford the vaccine. And vaccine preferably has to be given prior to the sexual debut. Indian Academy of Pediatrics and FOXY, they recommend that vaccine should be given in females from 9 to 45 years of age for prevention of cervical cancer. And ACIP and AAP also have recommended given HPV vaccine to males of 9 to 26 years to reduce the likelihood of acquiring genital warts and hence the transmission to the females. What are the vaccination schedules recommended by FOXI is age of initiation of vaccine is 10 to 12 years. Catch-up vaccine is permitted up to 45 years of age. 3 doses for this quadrivalent vaccine, that is the Gardasil, 0, 2 and 6 months, and 3 doses but 0, 1 and 6 months for the bivalent, that is the Cervarix vaccine. There is no need for the booster, no data to support the need for booster as of now. Now, vaccination for the sexually active women. Sexually active women and women with previous abnormal cervical cytology still can receive HPV vaccine. However, their benefits may be limited to protection against the HPV genotypes with which they have not been exposed. This vaccine can also be given to the patients with previous CIN, but the benefits will be again limited to the protection against the HPV genotypes which they have not been exposed to previously. There's a word of caution, it is not therapeutic, it does not cure cervical cancer, it is just prevention against cervical cancer. And what about HPV vaccine in pregnancy and lactation? It is not recommended in pregnancy. If the patient becomes pregnant, delay the remaining doses till delivery. And if vaccinated during pregnancy, there is no need for intervention, MTP is not needed. Lactating women can still receive HPV vaccine and continue breastfeeding the baby. But then the vaccinated woman should not sit home and say that I have been vaccinated, so I will not be able to get, I'm not at risk of cervical cancer. They still have to be screened. They have to be screened with pap smear yearly. Screen positive women may be vaccinated after counseling, and but screening, that is pap smear, is not required prior to vaccination. Now to summarize, HPV is the necessary cause of cervical cancer, association being around 99.7%. Induction of neutralizing antibodies by vaccination is critical for protection. HPV types 16 and 18 cause more than 75% of cervical cancer, whereas HPV 6 and 11 cause more than 90% of the genital warts. 27% of the world burden of cervical cancer is seen in India. Every 7 minutes, a woman dies in India due to cervical cancer. It is usually diagnosed very late, and cervical cancer screening, that is pap smear, is recommended as soon as the female becomes sexually active. It's not 30 years, it is as soon as the woman becomes sexually active. And vaccination can be started as early as 9 years to 45 years. It can help reduce the burden of cervical cancer in India. Now the next topic, sanitary napkins safety issue. Even this was an eye-opener for me because I never thought that sanitary napkins could be a safety issue for any one of us. So I had to search the net. Now most of the sanitary napkins and tampons are made of or bleached with chlorine compound that contains traces of organochlorine, that is dioxin. Dioxin is a highly potent carcinogen. Women with high exposure to dioxins can also have suppressed immune system, cause endometriosis, reduce fertility, and interfere with the normal fetal development. But sanitary napkins is a necessary evil, and an average woman uses approximately 15,000 pads over the course of her lifetime. The effect of exposure, continuous exposure to dioxin, which is forever stored in fat cells, may become cumulative and deadly. Now, sanitary napkin pads also harbor bacteria as they are not sterilized products. Unacceptably high bacterial counts of up to 11,000 have been found in some of them, which is more than 10 times of the international safety standards. This could lead to vaginal infections and then ultimately PIDs and various fertility issues also. Mostly we used sanitary napkins post-surgically also, after the C-section, after the delivery. Prolonged use can lead to contact dermatitis, itching and redness because they are mostly made up of synthetic material. Vulvar and vaginal infections because of the unsterilized nature of the pads. There are no safety checks on pads. Sanitary products like pads can be placed on the market, that is over-the-counter drugs, without prior evidence of safety or efficacy, even in the developed countries. Now what can be done? Maybe we can use sterilized cotton pads, autoclaved cotton pads after delivery, frequent change of pads to prevent infection, And there is a need for regulatory body to ensure strict quality control on these pads. The final word, what the ACOG says, all adolescent girls should have their gynecological visit between the ages of 13 and 15 to help set a stage for optimal health in the years ahead, including the reproductive health. Role of nursing care in adolescent gynecology, help counseling the teenager, ensure overall health, proper physical and sexual and mental growth, stress control techniques, and contraceptive advice. Thank you. I hope I finished within.
Thank you, Rampreet Kaur. I think your presentation has covered quite important topics, and particularly I have been hearing safety of sanitary napkins, and through this presentation my knowledge and experience, has increased so much that now I have to advise people, especially the adolescent girl, regarding this. Many things we do very naturally, follow things, but don't understand the risk. Thank you for the presentation.
Thank you, ma'am. Now I would like to call the Associate Professor of Lakshmi Bai Batra College of Nursing, New Delhi, Ms. Sarla Takku. She is having 38 years of experience and she has attended various national and international conferences. She is the Secretary of SOMI Delhi chapter. Ma'am, please show some light over the newer technologies in diagnostic method in gynecology and obstetrical nursing.
Good afternoon of the dais and on the dais and all the students and all the participants. So my topic is newer technology in diagnostic methods, gynecology and obstetrical nursing. Modern childbearing has brought with it new and expanding reproductive testing options. They provide women with information about their pregnancies. Of the 3 to 4% of babies born with recognizable birth defects, most are born in families without identified risk factors. Women are concerned about the health and well-being of fetus. Prenatal screening and diagnosis are offered to all the women in early age of pregnancy. Screening in both clinical and community contexts are promoted as a cost-effective means of identifying women having potential high-risk pregnancy. There are many new technologies that have come up to make diagnosis more accurate and faster. Even routine assessment in day-to-day postpartum care also, it has been evaluated to new levels with today's technology. The newer technologies are 3D, 4D ultrasound, then microarray analysis screening, targeted ultrasound, and cord screening test. Then there is cell-free fetal DNA screening. Coming to 3D, 4D ultrasound, with 3D ultrasound, it is a series of thin 2D slices which is digitally reconstructed to give more lifelike images. But with 4D ultrasound, the added dimension is time so that 3D images appear to be moving in a real, and we can easily look at the features on fetus or baby. 3D 4D ultrasound uses the same ultrasound as it uses 2D conventional method, but extra processing is performed by the ultrasound computer machine. 3D ultrasound is just safe, just like a conventional 2D method, and we can also diagnose other conditions, pelvic conditions like congenital uterine abnormalities. Some women are born with changes in shape of the uterus, for example, bicornate uterus, or we can say double uterus. Location of endometrial polyps, the location of submucous fibroid, and assessment of intramural component. We can also locate intrauterine contraceptive device when it has been abnormally penetrated in the wall of the uterus. And some of the investigations are also done when there is recurrent miscarriages and preterm deliveries. So this is the baby's image. You can see a golden color. It's done at third trimester. And this is the image of bicoordinate uterus. Next is ultrascreen instant risk assessment. This ultrascreen, why it is known as? Because it is done in the first trimester. This assessment is combined with the blood test with ultrasound to deliver the personalized risk for Down syndrome, trisomy 18 and trisomy 13. In first trimester screening, this is called, and it allows us the information about the health of the baby. This is the image of instant risk assessment. Next is microarray analysis screening. This is the screening where we can see study the chromosomes in detail, and it is based on the fact that we can detect the too much of genetic material and too less of genetic, and it also helps us to see the development of the baby. This is the new test using for gene chip microarray to analyze the various areas of human genome for abnormal region and contain too much or too few copies of genetic material. This chromosome screening determines if a person has extra duplicated or missing deleted genes that may affect the growth and development. So microarray, this is a gene chip. This is a map like which contains hundreds of tiny dots which separates the DNA, and we can look for the abnormalities. This is the gene chip. This is the efficient method of and accurate method of detecting the autism. Next is targeted ultrasound. Targeted ultrasound is self-explanatory. It can target or focus fixed part of the area, like use the state-of-art technologies. Sonographers use imaging to evaluate the baby's size and position and development. This technology also used as a component of diagnosing development abnormalities. Using the sound waves, there is no radiation. This is the image of targeted ultrasound. Next is cord screening. This is the blood test screen for detecting the open neural tube defects such as spina bifida, anencephaly, and for abdominal wall defects and chromosomal changes, for example, Down syndrome, trisomy 18. The screening are performed during second trimester, typically between 15 to 22 weeks of pregnancy. Cord screening test, we can see the 4 substances, for example, AFP, HCG, estrol in inhibin A. As you all know, alpha beta protein is produced by the fetus, HCG by the placenta, and estradiol is produced by the fetus and placenta, and inhibin A by the placenta and ovaries. Cord screening test, earlier we used to say the triple test, that it was done AFP plus double marker screening, like only AFP, HCG and estrol. The screening is essentially same as screening test, look for only 3 substances. The cord screening test involves drawing of blood from the mother. If the inhibin A is at high level, that indicates the Down syndrome. Then next is cell-free fetal DNA screening. In cell-free fetal DNA testing is a new screening test that indicates if a woman is at risk for carrying the fetus with Down syndrome, like trisomy 21 and Edwards syndrome and trisomy 18 and trisomy 13, that is syndrome. The screening can be performed early at 11 weeks of pregnancy and is used to know more about the baby's Rh factor and potential abnormalities from chromosomal abnormalities such as Down syndrome. This is a non-invasive test procedure, includes drawing of sample of mother's blood for evaluation. They can separate the fetal cell from the maternal blood and confirm about the diagnosis. Next is postpartum maternal physical assessment, which we used to do daily, day-to-day postpartum care. Postpartum assessment like bubbly, and second is assessment of episiotomy. Bubbly stands B for breast. We look for the breast, its size, shape, any whether it is erected, it is flat, mastitis and colostrum. We palpate its fullness, engorgement and lumps. We also do pain assessment. We also look for the fundus. We see palpate the fundus, its firmness, booginess, and fundus in relation to abdomen, and determine the location of fundus in relation to belly button amount of fundal involution. We inspect the incision site. Then comes the bladder. We look for the bladder. Normally, mother should void 30 ml per hour. We look for the distension, incontinence of urine, urinary retention, urinary infection, especially in patient having the Foley's catheter. Pani se? Then we have to look for the bladder, assess the bladder. We see, check the when mother has last moved bowel, and we ask for the flatus. We assess the distension and abdominal pain. Then comes lochia. We assess the lochia color and its order. We assess the postpartum hemorrhage. Then comes E for episiotomy. We look for the level of laceration, number of stitches, redness, edema, bruising, discharge, and approximation of wound edges. We assess the perineal area. Then H for Homan sign. We assess the Homan sign to diagnose the DVT. We do it by dorsiflexion of feet. Then comes emotional state. We assess the signs and symptoms of postpartum depression and infant-maternal bonding. Next is assessment of episiotomy. The word acronym is RERA, you all might be knowing it. We look the episiotomy for redness, edema, ecchymosis, discharge and approximation. Here comes the role of nurse, which is very important for us to play. Nurses participate in screening in a number of ways. They can be involved in planning, implementation, administering or evaluating and testing programs. It's important for the nurses to be aware of availability of potential impact of screening techniques. This will allow them to provide appropriate information and support the mother at each step. Basic understanding of screening principle is important for all nurses, and more in depth of knowledge of pregnancy screening tests, which is required in prenatal period. Informed consent is very important. Then nurses should help the client to understand that the blood test may not be only the first step, and other tests will be offered if the result is abnormal. The other tests may include both both ultrasound and amniocentesis. Nurses should be able to provide information about the availability of such procedures, how and when they will be scheduled, and where to find the additional information about them. Patients need to understand when testing is most accurate, when the screening window closes. In first trimester, screening is generally offered at 11 to 14 weeks of pregnancy, and second trimester screening is done at 15 to 20 weeks of pregnancy. The patient should know the specific details of testing process, such as where and when blood is drawn and how long it takes to complete the test. The nurses need to emphasize that the woman has time to consider any testing offered. She does not have to make decisions about accepting the invasive testing or pregnancy termination until she has adequate information about the same. Nurses may not have latest knowledge about every aspect of pregnancy screening, but each nurse working in settings where pregnancy screening is offered should establish their own network of resources for themselves and for their patients. Now summarize. Basically, a screening program is intended to detect complications early, provides the health education and implement the health promotive and preventive interventions. So nowadays we have newer technologies which are available to detect the defects at early stage to make early interventions. Thank you. I know I am very fast because of shortage of time.
No, but Sarla, I think you have handled it very well, and you have, handled the most recent techniques. Particularly, I am appreciative of the role that you have told about the nurses, which most of the time in hospital clinical setting we don't take much care to inform the mothers or the patient clients about the investigative technique.
We
Thank
should
you.
not
It was
advise
nice.
the mother, she will not go for all these tests. If first step is abnormal, then though these tests are very costly, like even 3D, 4D ultrasound, it costs 4 to 5,000, 5 to 7,000. So it's very costly. We have to see the risk assessment, the percentage of risk. If it is very less risk, then we go for the other tests. Thank you.
Thank you, ma'am, and thank you all. Thank you so much for your words of wisdom. It will be a great pleasure for all of us to listen to you again in our future events. Thank you. Now it's the time for a break, as you all must be feeling very hungry. So I request you all to please move to dining hall. We'll be resume here after 45 minutes. And it's my humble request, please be back after 45 minutes so that we can continue further.
I think we should all give a big clap for all the presenters. They have done a wonderful job.